Welcome to Healthy Lifestyle. I'm Lorianne Casdia. Our goal here at Healthy Lifestyle is to inspire, educate, and empower you to fulfill a healthy, emotional, spiritual, and physical life so you can feel empowered to live the life you have always wanted and dreamed. Today, we're going to jump right in. We have two different guests. Our first guest, and they're both from Northwell Health, one of our sponsors. Today, our first guest is Dr. Wasif Saif. He is the Deputy Physician-in-Chief and Director of Medical Oncology at Northwell Health Cancer Institute, and also a professor at Hofstra, Northwell, and a professor at the Center of Health Innovations and Outcome Research of the Feinstein Institute for Medical Research. Welcome to the show, Doc.
Thank you very much for inviting me.
Oh, please, our pleasure. Always good to have you on. So you are working in the advancement and treatment of pancreatic cancer, correct?
Yes, ma'am.
And there's something that you had said when we were speaking earlier about the treatment of cancer. You say you treat cancer patients, not cancer, and I love that. But what does that mean?
It really means very simple, because when you are dealing with a patient with cancer, you have to really have a very holistic approach and think about all the physical and the mental needs of the patient. And I think it's also important to understand the tumor is coming from the pancreas, for example, and pancreas has two major functions. Pancreas is the organ in the body that produces a very high level of digestive enzymes that help us to digest food. At the same time, pancreas is also the store or the resource of insulin and glucagon, where these glands produce those hormones and help to control your glucose level. So I think even you look at the example of this one, it means that when patient comes to see you with cancer, you're dealing with cancer symptoms, but at the same time, patients will also have malabsorption and glucose issues. So I think the whole point is that when patient walks to my clinic, I have to take that patient as a whole and make sure that I will take care of his cancer treatment, also his mental needs, his physical needs, and provide the support. And I think that's the reason I always say that I don't treat cancer. I treat the cancer patient. Because
yes.
It is a connection between a human to human.
Yes, because you're looking at the person holistically. You're looking at everything, and no illness. It doesn't matter if it's cancer or COVID. No illness is just that particular issue. It usually has other issues that have pointed it or put you in a condition where your immune system was weakened to allow you to have that condition to the point where it's really acute. Correct?
Exactly.
Yeah. So some questions come up, and I've been asked a question before is, why is pancreatic so difficult to diagnose at an early stage? It's usually people are catching it later stages. Why is it so difficult?
Sadly, there are not really any noticeable signs or symptoms in the early stages of pancreatic cancer. At the same time, the signs and symptoms of pancreatic cancer, when present, are like the signs and symptoms of many other illnesses, like ulcer disease or gallbladder issues. At the same time, pancreas is hidden deep into the abdomen between the stomach and the spine. And sadly, till it has really spread to distant organs, we are not able to really notice that thing. And I think last but not the least, also at this time, we have no screening test for pancreatic cancer like we have available for other cancers, such as the mammogram for breast cancer.
Are there any known risk factors?
There are known risk factors to development of pancreatic cancer that may include smoking, overweight, personal history of diabetes mellitus, or chronic pancreatitis. I would like to mention here that diabetes mellitus, it is a very interesting relationship. It's like a chicken and the egg. Historically, we believe that chronic diabetes can lead to development of pancreatic cancer. However, over the last decade, we learned that patients who are lean and does not carry a family history of diabetes mellitus, if they develop diabetes, it could be a signal that somebody may be developing pancreatic cancer.
Understood. Okay, that made a lot more sense to me. And are there genetic factors that lead to pancreatic cancer?
Yes, there are certain hereditary conditions that we believe predispose a person or individual to pancreatic cancer. The most interesting one that we are talking a lot these days is the breast and ovarian cancer syndrome, so-called BRCA1 and BRCA2. In addition to that one, there are some other syndromes also, such as what we call HNPCC, hereditary non-polyposis colon cancer. Also, there are syndromes when people have melanoma and pancreatic cancer running in the family. So definitely we're learning more and more about the genetic, predisposition to pancreatic cancer over the course of time.
Is there anything we can do to sidestep that?
I think, first of all, it's very important to really have a very good family history of tumors in a patient. I think that's the key element. At the same time, as we learned over the last few years that, breast cancer gene BRCA1 and BRCA2 not only increase the risk of ovarian cancer and breast cancer, but also it can enhance the risk of pancreatic cancer. So these are the patients that we need to start, learning about them and may start screening them at an earlier stage and maybe looking at imaging of the pancreas and looking at their symptoms very carefully. So these are definitely learning points that we're doing. And even at this time, the national organization do recommend that patients who are high risk for pancreatic cancer should be screened, because I told you otherwise for the general population with average risk, there are no screening tools available at this time to look for pancreatic cancer.
So if there are no screening tools right now, how do they screen?
So what we do, we do diagnostic tools that we use in a patient where there's a suspicion of pancreatic cancer. So one of the tools is really to what we call endoscopic ultrasound, which means just like going through their mouth into the stomach and to the small bowel, they can visualize with a small camera into the pancreas and look for any obstruction of the duct or any mass in that area.
Do they do that typically with an endoscopy? Or is this... Ma'am. Oh, they do. So every time I get an endoscopy, they're checking for that?
No, they are not, because it depends upon how far they are going, because endoscopy could be just done for esophagus or stomach. But if they're going all the way into the duodenum, which is the first part of small bowel, then they may be doing it. But again, it's all based on what is the reason they are doing the endoscopy in a particular patient.
So on a typical, annual endoscopy, colonoscopy scenario, they're not going that deep. And is that would that be a good thing to have to become a standard when you do an endoscopic exploration?
First of all, you have to understand that a lot of general gastroenterologists may be able to do an upper endoscopy. But for somebody to looking for pancreatic mass by doing further advancement of endoscopy has to have a special expertise in that field.
Yeah.
At the same time, we also need to learn, that if we see something, what we are going to do after that. And thirdly, also, we need to look at, the cost benefit of doing those screening. And last but not the least, we also need to make sure that what is the risk attached to those procedures in patients. So I think right now, we do not recommend that one out of the context of a high-risk definition of that particular individual person. So we do not do the endoscopic ultrasound, looking for pancreatic masses at this time.
Understood. And before we started, just to track back for a second, we were speaking about treating cancer patients. And so what are your biggest challenges in treating cancer patients?
The biggest challenge is the fear in the patient.
Yeah.
They're so afraid. I think when you have pancreatic cancer, I think it's easy to say than to go through. And I think the fear, the scare that they have in their body, in their eyes, you can feel it when you hold their hands. You can feel those trembling hands. You can feel that soul is shrinking down because people are so scared.
Well, it's the unknown, right?
Exactly, unknown, and then also the suffering, which is affiliated with the complications of pancreatic cancer.
Yeah.
And the outcome, and looking at your beloved one sitting next to you, that you may leave the world and leave them behind. So I think that is the biggest challenge that really trembles me inside and my soul, and that's the reason it has made me who I am today, because this is really something you have to be very, very sensitive about.
Yeah, clearly. And I love the fact that you are. And I find that at Northwell Health, the educators or the doctors are always consistently educating and being compassionate. And that compassion definitely rings through with you and true to you. Are there any new drug approvals for the FDA in the last year or so regarding treatment of pancreatic cancer?
That's a very good question at the right time, because we were just talking about, the genetic predisposition to pancreatic cancer and the hereditary conditions. And interestingly, last year, a drug called olaparib, it is OLAPARIB, is an interesting drug which was approved by FDA to be given to patients who have pancreatic cancer, but those patients have germline mutation of the breast cancer, ovarian cancer gene that I was talking to you, BRCA1 and BRCA2.
Right.
It was found that these patients, after they receive the chemotherapy for the initial 16 weeks, when they're given this drug, it can really add a benefit to their disease control. So this is an exciting time that now we can really offer a specialized drug to patients based on the genetic composition of their tumor. So having the germline mutation of the BRCA1 and BRCA2, now we have an agent to be given to these patients in addition to systemic chemotherapy that we treat in other cases.
Oh my gosh, that's so exciting.
Exactly.
Oh, that's so good. So where do you think the future is for the treatment of pancreatic cancer?
I think the future is really how to utilize all the agents we are successfully able to develop into different regimens over the last few years. We also need to understand, that why some patients do better than others. We are really trying to go and understand the biology of the tumor, and the exciting things are happening that we at Northwell are going to be, collaborating with our scientists at the Cold Spring Harbor Laboratories, where we are going to be looking at the tumor, profiling through the organoid. And you can imagine organoid. Organoid is basically a small miniature tumor you are going to develop from the cancer cells.
Right.
And by really testing different drugs onto that, that petri dish cancer, you may be able to understand the sensitivity of the drugs to the patient cancer, and then you may be able to offer those drugs based on that, information we gather from the organoids. At the same time, immunotherapy. We learned about immunotherapy or immune therapy over the last few years for many tumors, including the most common cancer, lung cancer, for example, and melanoma. We also need to understand why we are not able to be very successful with pancreatic cancer treatment with the immunotherapy. And I think we are trying to figure out and combine different agents or trying to look for novel agents to really see how to make this cancer more immunogenic and have some benefit by offering those drugs to the patient. So I think it is an exciting time in the sense that science really is developing in different directions. Yes, pancreatic cancer is a tough cancer, but the good news is that, now we're working with our basic scientists together. So we're trying to combine the science, and at the same time, we learn from the patient. The patients are part of the team, and we learn from them, what are the symptoms, what happens, and things like that. So it is definitely going to take some time, but there's no question that from today compared to when I was in training, we are able to offer much more options to these patients and much better quality of life and much longer survival.
Yeah, it doesn't sound as terminal as it used to. You used to hear someone had that, and you thought, or one would think it was a death sentence, and I'm not hearing that right now. So it sounds very exciting, and you guys are really taking a lot of steps forward. Have you seen a lot of those forward movements in the last few years, or have you seen it equally grow over the last 10 or so years?
I think there's no question, that with the regimens called FOLFIRINOX and GEM-Abraxane and nanoliposomal irinotecan, adlotinib and olaparib. So I think there's no question that we're able to develop so many agents over the last few years. And I think selecting the right patient to give these patients either in a combination form or in a sequential form is able to really make the survival prolonged in these patients. And at the same time, we're working very closely with the radiation therapists. Instead of giving like the old way of giving radiation therapy, now they can give a short, high-dose radiation therapy to a very dedicated area. Our surgeons are getting much and more, comfortable with their expertise. Even in patients with isolated metastases, they are willing to take that patient to surgery after we really sure that this is the only site. So I think it really takes a village to really go to the next stage of success. And I think keeping the palliative care, the nutritionist, genetic counselor, surgeons, medical oncologists, radiologists, pathologists, and I think that is the approach that is really leading to us to the success.
Yeah. And I like the way you say that. It takes a village to get to the next level of success. I really like that you say that. One other thing that I noticed, and it was just very warming, and it really speaks to who you are as a human and as a doctor, is that the most inspirational person for you is your mom. And I just love that you point to that, and that you have a really great inner satisfaction and gratitude when you see the gratitude in patients' eyes and in their families' eyes because of how you're helping them out. How does that make you feel?
Listen, I become an oncologist and I deal with pancreatic cancer. So, when you go to public or talk to your friends and families, they say, why you are doing pancreatic cancer? It's so depressing, it's so difficult. And I tell them, if we all keep thinking that way, we will not even able to reach where we are today. So the point is that, when you get cancer, you are not asked by God or fate, okay, are you going to get this cancer or that cancer, which means it can happen to anybody.
Right.
And despite all the research, we know that, the incidence of this cancer is markedly increased over the last several decades. So that's number one. Number two thing is that, again, cancer or non-cancer, we all know that every disease can lead to a fatal outcome. So the bottom line is that, that helping these patients with a feeling. And, the way my motto has become very different. The way I look at becoming an oncologist in my life has changed over the last 20 years. I always tell people that, my philosophy is that when you are dealing with pancreatic cancer or any disease like that, you feel like you are working like a prophet. And people say, what does that mean? And I say, it only means one thing. Do everything right and don't look at the outcome. Because the outcome is in God's hands, but you need to do everything right. Just like even in the prophets, you can crucify, you can hit stone, but end of the day, you keep doing the right thing. I think that's what makes me happy because I keep doing whatever I think I can do for my patients. Either it's the treatment selection, either it's the moral support, either to manage their symptoms. Keep doing the right thing is the key element because, that's the connection that you become a part of their lives and the parts of their families, and that's what makes me so happy and satisfied because, it feels like what people say that you touch somebody's life. I cannot take that credit. I think they touched my life. They made me who I am. And I think that's a blessing.
Oh, that's so beautiful and so, so accurate. I love that you don't look at the outcome. That's out of your hands and you look at doing the right thing. And if we all would just look at doing the right thing, this world would look entirely different. And what you're doing is magnificent. So in the last few minutes, so why did you become a doctor? What was it?
So, that's a very interesting story. And, all I can say that I was supposed to be a scientist. We are four brothers, and I was supposed to be a scientist. And the honest answer is that my elder brother wanted to be a doctor, and he couldn't get into the med school. And my mother asked me she told me that, all the sons are good, but I think that you have something that you can do whatever you want to do, and you will be successful. And keep in mind that back home at that time, we don't say no to our parents because parents are like after God.
Yes.
So that's how it happened to me. And then when I really want to become a doctor, I wanted to be a cardiologist. But then I lost somebody in my family due to cancer. And the way that person suffered and the way that person, expired was a very heavy burden on my chest and in my mind. When I came to the United States, the first thing I learned that we should not let people die in pain and suffering. And I think that became my revenge to cancer. I don't think when people ask me that, how are you always so passionate and so energetic? I just tell them, because this is a personal fight. I take cancer personally. I'm the enemy of cancer, and that's the reason. And I think there's always a reason behind for things, but I think God has a reason for this thing. And believe it or not, if I get another life, I will become an oncologist again. I have no regrets.
Oh, that is so amazing. What a great story and so true. So often we find our way in what our purpose is while we're here through watching something that happened in our life that was so disturbing and or magnificent that you have to do something about it. And story after story, when I speak to people and ask them why they get into what they do, it's generally something that has been affected. They were affected personally by, and they felt completely out of control or not having any control over it, and they learn and they figure out a way so that they can at least contribute. And that's exactly what you're doing. It's just a totally amazing story. I love your passion about what you do, Doc. It's a really wonderful thing. Thank you so much for joining us today. I really, truly appreciate it. I know we all feel blessed for having spoken with you, and I hope you do come back.
Thank you very much.
You have been speaking and listening to Healthy Lifestyle with Lorianne. We were speaking with Dr. Wasif Saif. He is unbelievable pancreatic cancer doctor and working in the Oncology department of Northwell Health Cancer Institute. And what a wonderful, inspiring story and good news that we have some good research going out there and a better level of success with pancreatic cancer. So that is wonderful news. We are going to come back with our good friend, Dr. Benjamin Schwartz, right after these messages. Welcome back to Healthy Lifestyle. I'm Lori Ann. If you have any questions, comments, or ideas you'd like to hear more about, please email us at healthylifestylewithla@gmail.com. And of course, follow us on social media at Healthy Lifestyle with LA. We love your questions, and they're always really good. So keep them coming. And if you have any ideas, please bring them to our attention. We truly appreciate the interaction from our listeners. So this afternoon, in our second segment, we have our good friend, Dr. Benjamin Schwartz on. He was named the Regional Director of Obstetrics and Gynecological Area for the Northwell Health Eastern Region, as well as the Chairman of the Department of Obstetrics and Gynecology at Northwell Health, a Southside hospital. So I love having this doctor on. He has so many great ideas. I don't know if you remember the emails in the OR that he has that program going on. And I want to check up on the new Urban Zen program and how that's going. Doctor, welcome.
Thank you. Hi. Good to talk to you again.
Good to talk to you too. So update us on the new Urban Zen program and how's it going?
Yeah, I mean, it's really exciting for us. We partnered with Urban Zen, which was created by Donna Karan of fashion fame. When her husband fell ill, she felt that the experience that her family had with healthcare felt very sterile and uncomfortable and not very humanistic. And she created this company that offers what we call integrative medicine services, which are, for example, aromatherapy and meditation and positional therapy to treat not just the disease with medicine, but to also treat the whole person and to help them navigate through the stresses of going through, as in my practice, the diagnosis of cancer and the surgeries and chemos and things that go along with that. The experience has been terrific. The services provided are free of charge to our patients that come through our practice at Northwell, and specifically the gynecologic oncology practice. And it's not just for the patients, it's also for our staff who have to work at times, particularly in a coronavirus era, under quite stressful situations.
Yeah, sure.
And it's really been a terrific part of our practice. We were afraid that in the midst of everything that was happening around us, that the program would be sidelined temporarily, but in fact, we've embraced it, and it's been a very important part, not just for the stresses of our cancer patients, but also for our frontline heroes.
Yeah, no, without a doubt. I mean, this would be the time that it should be robust. I am a certified aromatherapist and herbalist, and so of course I believe in meditation and all those wonderful things to keep you in alignment, as much of alignment. So when you have a medical situation, you're not fighting against yourself. So I think these are great practices. And I'm so excited to hear that it's continued and it's as robust as before. And I love that your staff and the nursing staff and the medical staff also have access to it, because that's really important. You all see a lot of stuff that's not so wonderful. And it kind of brings me to a question, because I hear a lot about this, people being worried about the safety of hospitals, especially during this time. So why don't we talk about that a little bit? Because I think that you are taking steps to keep our hospitals safe and keep the patients safe while they're doing things like having babies, right?
Yeah. So as most people know, when the crisis first hit our area, it was necessary for us to turn off, if you will, some of the medical services that we were providing, particularly as relates to elective surgeries, and we tried our best to limit the amount of office visits that we had in our offices down just to those that were absolutely necessary. But babies don't stop coming,
yes.
And prenatal care doesn't become unnecessary. And for your listeners that are aware of, the difference between essential and non-essential services, providing obstetrical care to expecting moms and their unborn children became a really important priority for us, because we knew that we couldn't just ask them to come back later. And so we put a lot of processes in place, particularly during the apex of this pandemic, at least in the New York area, which was about a couple of weeks ago. Over the last several months, we've put into place various procedures and policies that are meant to, and I think we're quite successful at preventing the risk both to the mom and to the baby of coronavirus infections. Initially, for many of us, and I think, your listeners will appreciate this, as most of us are spending a lot of time at home and are becoming very educated about coronavirus. When the crisis hit initially, there wasn't a lot understood about the virus, how to treat it,
sure,
who would get sick, why people got sick. And that meant that it required a very extreme approach to isolating pregnant moms from their families if family members were sick, sometimes from their own doctor, whereby we limited the number of physicians that were able to practice in the hospital, and we actually created venues away from the sicker patients in the hospitals that we felt were safer places for patients to recover during the postpartum period.
Right.
Now, as you've heard over and over again, it's all about testing. We're proud at Northwell Health to be leaders in our communities with regards to testing. And as we're now able to test patients and providers quickly and get answers quickly that we believe are accurate, we've been able to put in place policies that make it as safe as humanly possible for a patient and her baby to come to a hospital, safely deliver, and leave without being exposed to sick patients with coronavirus.
Sure.
And so while we have those sick patients in the hospitals, and I don't think there's a hospital in Long Island right now that doesn't, these venues are really, really clean and safe and certainly make a lot of our fears and concerns about not knowing everything about the virus less important.
Yeah, well, I think we've gone through this before. I think this particular or similar type of a virus, like H1N1, that was pretty rough, and we had some record losses, but we weren't taking stats as much back then. We also didn't have social media 24/7 and news 24/7, so we didn't have this communication tool, which has its positives and negatives, sometimes more negatives than positives, by having all that information out there. But so while you were going through that past pandemic, it didn't have a same vibrancy out in the general public. So I love how you said that we took a reaction to say, well, we're not sure, so we're going to protect everybody, make sure everybody's safe. And as we learn more about it, we're going to be able to let you know, and that you have the rapid tests now available and you're able to keep people safe. So does this look that much different than previous pandemics that we've experienced to you?
Well, yeah, I think it is very different insofar as, I don't remember in my lifetime a disease like this where our health systems, and I say plural because I mean all health systems in the New York area and across the world, were really in fear that their capacity would be overrun with too many sick patients and not enough resources. H1N1 and other diseases in the past, terrible diseases, Ebola, and others, highly infectious, highly fatal. But I don't remember in my lifetime ever working in a space where so many patients that are in the hospital were on ventilators, and there was a real fear at one point that we would not have enough ventilators to go around. A lot has been said, I think, over the last decade about the role of the media in society, and, some have used the term quote-unquote fake news. But I think, part of the unsung heroes in flattening the curve in New York in particular has been the media, the awareness of everyone of what's going on, that almost all of the information that was broadcast and that is being broadcast has been spot on accurate and honest and with a certain degree of humility with regards to what we know and what we don't know. And it's only because of the policies that were put in place and the behavior of our public that we did not get to a point where we were overwhelmed and did not have enough ventilators.
Well, we should be very proud of the public for really being responsive to this and really doing what they were being told to do. I think that's an important element too. But why don't you just share with us the story? I know you have a story about a mom who had a C-section while on a ventilator. So what was that? What was that like?
Yeah. So we had a patient that came to the hospital who was healthy. She was a mom of 3. And at around 34 weeks pregnant, came into the hospital with severe respiratory symptoms. She had a fever, she had a bad cough, she was very short of breath. It was very obvious quickly to her providers that she was suffering from coronavirus-related pneumonia. And that was complicated because there was a lot of discussions with her about delivering her baby early, which we thought might help her lung disease and her virus disease, versus keeping the baby inside so that it would have more time to fully mature because it was preterm. So when she came into the hospital, she was admitted and the baby was checked and was okay, and she was taken to the intensive care unit. And within a matter of 24 hours, she rapidly deteriorated to the point that she could not breathe on her own. She was not getting adequate oxygen. And the decision was made that the baby had to be born right away, not only with the hope that her pneumonia would get better by doing that, but also out of fear that the baby would not tolerate low oxygen levels and might even die. So we were planning on inducing her labor because she had 3 children before. We thought, this is not a very big baby. It's early, so maybe it would be easy for her to have a normal, natural birth.
Right.
But her lung condition deteriorated so quickly that she had to be put on a ventilator. And the decision was made to do an urgent cesarean section. So the doctors on our team did the C-section. The baby did great, despite the fact that it was born early. We moved him. The baby's name is Walter. We moved Walter to our children's hospital in New York City, mostly out of an abundance of caution. And the mom remained on a ventilator for 11 days. She was critically ill. It was, at that time, if you ended up on a ventilator, 4 out of 5 patients that were put on a ventilator did not survive. And so everyone in the hospital knew about this mom, knew the story, and were very fearful that she was not going to do well. And with each day that she was getting worse, I think we all were sort of trying to emotionally wrap our minds around the idea that she was not going to pull through. But with an incredible effort on the part of everyone involved, the doctors, the nurses, the pharmacists, everyone, including the patient, she rallied and did incredibly well. She came off of the ventilator despite being critically ill after 11 days, woke up, was completely okay, and sitting in a chair and speaking, and was discharged a couple of days after that. So what was so touching and moving about this whole story was that everyone in the hospital knew the story of this patient, and when she started to do well, it really kind of lifted the spirits of the entire building.
Sure.
So much so that when she was discharged, the entire hospiel came down to the lobby to applaud her leaving.
Oh, that's
really
such a wonderful story.
It was great, but what nobody knew was that we had made arrangements with her family, since the baby had been discharged the day before, for her to be reunited with her son and to meet him for the first time right outside the lobby of the hospital.
Oh, that's so wonderful.
Yeah, it was really overwhelming for most of us. I don't think there was a dry eye in the space. And just for us, it was just kind of this magical reinvigoration of hope and spirit that here this family had been made whole again out of the work that everyone had done, including the patient. And I think when everybody walked back into the building after that moment, they felt, that there was hope, that this pandemic will end, that we will be able to save lives. And so many lives have been saved since then. But at the time that this all happened, we didn't know how many people would do well. And it was certainly an amazingly uplifting experience, particularly in light of the fact that not everyone does survive, and many families have been devastated
What a wonderful...
having a victory was great.
Yeah, what a wonderful happy ending story, which I love, love, love. But even on top of that to give that feeling of hope and that you all are making a difference. You always feel and hope that you are making a difference. But this was actually showing and proving that you are making a difference, probably resurged the energy in everybody who works in the hospital and also some patients in the hospital, because it probably spread as rapidly as this situation has. So that's exciting. That's so exciting. I love that story. So
thank you.
Let me ask you a question, and congratulations for that. That you should be very proud of that, and I'm glad that you are.
Thank you.
How will you be delivering babies in the future? Post-COVID. Do you know what that's going to look like?
Great question. I think, so the first thing is that everyone needs to know that the governor did create a task force that was and remains in part has physicians and nurses, but also has members of the community and some celebrities that are asking some of the questions regarding this. I think, some of the good that comes out of the COVID disaster is that it has forced healthcare providers to look at how we provide care and are there opportunities to do things differently. I think certainly I've heard a lot of people liken this crisis to 9/11, and there isn't a person who doesn't know that the security that we used again to go through airports has changed a lot since that event in history. I think how we provide healthcare will be similarly changed. I think we will be screening patients more for infectious diseases like this. I think we'll be looking at opportunities to reduce the amount of time that patients have to be in the hospital after a surgery or after having a baby. Who provides the care in terms of who actually does the delivery and will certainly be another question. I think the role of midwives and others will be more and more important in the future. I am sort of concerned, which is not exactly your question, but I am a bit concerned that I'm aware that some families, out of fear of going to hospitals, are considering having their babies outside of a hospital. And I would just try to discourage families from considering hospitals as being a dangerous place to go. We know statistically that most of our COVID infections have happened in the community or in homes and not at hospitals.
So that lends me to a question that I had, and I wanted to end on this, is what would you say to women who are pregnant now and concerned about delivery?
Well, the first answer to the question for sure is that as best we know, the unborn fetus is not really at risk from the viral infection of the mother. We've not recommended at Northwell Health any additional or special prenatal testing or ultrasounds or anything else because we don't believe there's a danger there. I think the really important advice that I can give to moms now is that the hospitals are really safe. We've taken great lengths to make it that way. But remember that most folks, when they go home with their baby, it becomes kind of a focus where family members come to visit. And sometimes family members have to be there to help take care of the baby. And we worry that sometimes a newborn child brought into a home may make people less aware of social distancing. And we still do have to protect the baby. We still have to protect the family there. And it's important for people to practice good hygiene, hand hygiene, wearing a mask if they're fearful that someone in the family could be sick. We've learned through testing not just the patients but also their significant others when they come to the hospital that many people do have coronavirus even if they don't have symptoms. And so it's really important for everyone to practice an abundance of caution when they go home with the baby to make sure that the newborn doesn't get an infection once it's home.
Wonderful, wonderful advice. Thank you again, Dr. Schwartz, for being on. We always love having you on. Look forward to having you on again. Thank you for giving that advice. Thank you for giving us hope and for everything that you're doing to make us all safe while we have to use and need to use our hospitals and feeling that feeling of calm that the hospitals are safe. So thank you so very much. I appreciate it.
You're welcome. Thank you so much for including me. I really appreciate it.
Always our pleasure. Thank you all for joining us today on Healthy Lifestyle. My heart is lifted by sharing this time with you. I want to thank my guests today, Dr. Benjamin Schwartz, and of course, Dr. Wasif Saif. They are unbelievable doctors at Northwell Health. What a great organization we have in our backyard. Great medical physicians and staff and support staff are real heroes of the world. And as I always say, we are here to serve one another. Clearly, they do that on a daily basis. So I'm going to ask you to take a moment, step out of your day, and do a little something for someone else. It doesn't have to be big, but just remember that everybody's having a different way of dealing with things. So just check in with 10 of your friends just to make sure that they're doing all right. In the meantime, I want to thank you for joining us on Healthy Lifestyle. I'm Lorianne Casdia. Until next time, play a higher role, serve a higher purpose, show up for you, and show up big.